Here is a depiction that actually comes from a T-shirt that you get to wear if you go to Carl Wasserman's cardiopulmonary exercise practicum that he puts on twice a year. It's not an advertisement, but suffice to say that it describes quite nicely, if you take the peripheral circulation and the pulmonary circulation into account, that the lungs will inspire oxygen and the heart will pump to the lungs. The O2 flow will be delivered to the tissue from the left side of the heart, at which point the tissue will respire and the mitochondria will produce CO2. CO2 flow will come back through the heart and lungs and get expired. And that is the basis, along with this slide, for gas exchange measurements in patients with cardiovascular disease. We know that in aerobic tissue, as I just described, oxygen goes in, CO2 goes out, and you can measure that. I'll show you in a second. But in an aerobic situation, you have the additional production of lactic acid, which gets buffered by bicarb and results in increased CO2 so that you see excess CO2 in relation to gas exchange during exercise when you become anaerobic. The underlying pathophysiology, as we all know, with precapillary pulmonary hypertension or group 1 PAH has to do with an intrinsic disease of the pulmonary circulation. And if you take a bunch of these lung units, we have millions of them, and look at rest, many of them are not open. They're not needed because the cardiac output at rest is normal and low relative to what happens with exercise. And as you see with exercise, those lung units respond and they open. And you'll see later on, hemodynamically, this actually translates into a slight drop in pulmonary vascular resistance because the number of lung units opening and the increase in flow actually surpasses somewhat that of the increase in pressure. The problem with PAH, and in particularly precapillary pulmonary hypertension, there is a problem with opening the number of lung units to maximum, so that if your cardiac output was supposed to go from 6 liters to 40 liters per minute, it really might go from 4 liters to 12 liters per minute. It might triple when you're running upstairs. However, it won't get to that amount that you need, and you'll become anaerobic sooner, and you'll tire out sooner. So the basis here is that the increase in pulmonary vascular resistance leads to right ventricular failure, pump failure, which blunts that increase in exercise cardiac output and leads to a VQ mismatch, but also leads to a reduction in the increase or a blunting of the increase in oxygen delivery to the tissues, which means the whole purpose of oxygen in the tissues is ATP production for energy to move the muscle. That's blunted. And as I mentioned before, the lactic acid production results in increased CO2 production. And overall, you get symptoms of dyspnea and fatigue. We can measure the VQ mismatch by looking at the ratio of ventilation to ventilation of air relative to the ventilation of CO2, which is lower than it should be during exercise. And we can also look at the oxygen delivery to the tissues, or the blunting, if you will. And we can look at the production or the appearance of excess CO2 in the form of the anaerobic threshold, which we can show non-invasively nicely. The problem with PH in general is that most patients aren't symptomatic at rest. Unless they're late class 4, they don't look like they're sick. In fact, it's a problem for their family and friends because they get told, they get asked, why do you have a wheelchair? Why do you have a handicapped parking sticker? Why can't you do the laundry? You look fine. They don't get it. They don't get the understanding that the blunting occurs during exercise. So here is me and Dr. Sun, our former associate who's now back in China heading a big pulmonary vascular group, sitting on a cycle, showing you how the nose is clipped so that when we measure molecules of air and O2 and CO2 going in and out, it all comes out the mouth. And this is probably the hardest part for people in general. I've done it many times, in particular scleroderma patients who don't have a big opening and getting that mouthpiece in. But everything is recorded there at the flywheel and at the sensors in the system behind. And you see also that there is EKG monitoring, there's a blood pressure cuff, there's a pulse oximeter. So we get all these measurements, which again, non-invasively provide kind of a wealth of information at rest, not to mention during exercise. We do cycle ergometry because we feel that patients, while they might get more vigorous exercise by upper arm movements with treadmill, they also are PH patients who are prone to passing out. And falling or stuttering on a treadmill can be disastrous for a normal person. I've fallen off a treadmill once. Taken off my sweater, I lost the visual clues, and my legs decided to not continue, and I fell back. And had I not missed the weights behind me by a few inches, I probably would have had a pretty severe head injury. So we like to keep them on a cycle. Plus, we've defined a lot of the parameters based on cycles, so we know kind of the normal parameters and the expectations of what a particular patient should look like, normal and disease. We don't do it encouraged because we want to make sure that we don't push the patients too far, first of all, and second, so that the peak levels aren't affected by the tester. We also do 3 minutes of rest to establish a baseline. We do unloaded cycling, which is basically pedaling against the weight of your own legs, and then we do usually 5 to 10 watts per minute of an increment, and it creeps up slowly. So every second it goes up by a little bit to a max of about 10, maybe 15 watts for the less impaired. You and I, in a situation, if we didn't have PH, if we didn't have cardiovascular disease, we probably would be placed at a 25 to 40 watt increment. So this is a gingerly step increase. And the idea is to complete the study in 10 minutes, around 8 to 12 minutes. So here's what you see. In the red, you see a matched control for a patient, matched by age, gender, and height. And that person in the red has an anaerobic threshold, about 1 liter of oxygen per minute before they come anaerobic. And then as you see, the slope of that line changes abruptly at the 1 liter mark, and it starts to rise faster because CO2 on the y-axis is increased more than VO2 was prior to the anaerobic threshold. So that was what Carl figured out in the late 1950s, that you could actually measure anaerobic threshold, and if you were to look at lactate levels in the blood, it would correlate fairly closely with that mark at 1 liter per minute. Now, in the idiopathic PAH patient, you see not only a lower anaerobic threshold where that break point is lower, but also you see the peak on the x-axis only goes to about 1, where the peak on the x-axis in the red goes to almost 2. So they have a low oxygen consumption and a low anaerobic threshold. Now, the problem with this is this in of itself could be due to a lot of different things. It could be due to the peak VO2 lowering could be due to an effort-related sort of thing where they just don't try very hard. It could be due to a musculoskeletal abnormality where they're not able to try very hard. And the low anaerobic threshold could just be due to being a couch potato and being extremely out of shape. So we look forward to, we look further to something called ventilatory inefficiency, and it's that VE-VCO2 I was talking about. Here is a showing of one of the graphs, one of the plots on our publication from Circulation now 15 years ago, where we looked at severe pH and moderate pH, and we called it primary at the time, compared to normal. So you see that VE-VCO2 starts off to begin with as very high. Now, when it starts off high, just like in the normal, it's probably because the patient is hyperventilatory. When they get towards exercise and you see out to 12 minutes, that normal goes down to around 25 ratio of VE-VCO2. That's because it's pretty tough if you are hyperventilating to continue hyperventilating while getting towards your anaerobic threshold and beyond. In other words, it's pretty hard up here to be focused on something like fear that is causing you still to breathe heavy. You're really trying to push the pedals and trying to go forward. So nevertheless, the resting levels are higher in PAH, as you see here, 40 for the moderate and maybe almost 50, and they fail to decrease during exercise. So you see that point during unloaded cycling and during exercise, it's not going down. In fact, in the most severe case, it's actually going up. And then with recovery, it goes up, so we kind of try and mask that off. But this is what we call a pulmonary vascular limit to exercise. So if somebody has a low VO2 and it's because they aren't perfusing their lungs, the VE-VCO2 will be high, and it's what I call the fingerprint of the abnormality in pulmonary vascular disease. It really helps us differentiate low anaerobic thresholds, low VO2, and symptoms of dyspnea. Here is a paper that came from the folks at Harvard who did this and more. They looked at catheterization, and they found, lo and behold, that exactly the same number, 34 and above, was their cutoff for what they determined a pulmonary vascular limit to exercise. So that's at the anaerobic threshold, which I showed you in the graph here, is usually around the nadir, the lowest point before it starts to go up. And that point of 34, as you see in the moderate and the severe, isn't close. It's not very borderline. It's fairly obvious. And in the normal patient, it's fairly obvious that it's in the 20s. So the optimal sensitivity specificity for detecting a pulmonary vascular limit to exercise happens to be right around 34. Doesn't mean 33 is not, doesn't mean 35 is always pulmonary vascular disease, but it's pretty good in terms of accuracy. And indeed, we showed in 2010 that the VE/VCO2 in the majority of patients in our clinic of 103 patients, 5-year outcome, the patients that had the VE/VCO2 less than 40, if they didn't have a right to left shunt, meant that they were protected. In fact, none of them died when the VE/VCO2 was less than 40. About 25% of the patients had a shunt, and there was an odds ratio of about 10, 11 to 1 that they would die prematurely or have a death in 5 years relative to the non-shunt patients. But if you didn't have a shunt like the other 75% and your VE/VCO2 was above 40, you had bad survival. That's the dashed line there just underneath. I don't know if I have a pointer here, but the dashed line that's completely horizontal and it's hiding behind the solid line at 100% is the survival 100% with the VE/VCO2 less than 40. Oh, okay. I didn't know if you all would see my pointer if you were at the satellite, so I was trying to avoid it. Okay. So, and it turns out that you can actually use an entity known as the end-tidal PCO2, which is really supposed to approximate the arterial CO2. And there's a relationship there that the lower the end-tidal CO2 is, again, at the anaerobic threshold, the worse the patient is. So high VE/VCO2 or low end-tidal CO2. And here's the relationship between the two of them. They're usually linear in the range of around VE/VCO2 30 to 50, which is about the working range of where most of these patients are. So it's almost the asymptotic line for this parabola. But in the very low VE/VCO2 range, it doesn't change very much, while end-tidal can really improve over time. And at the same time point in the far right on the x-axis, in those patients who have very little change in end-tidal CO2, either in response to treatment getting better or in response to getting worse over time, there isn't much of a change in end-tidal. So in the very severe patients, we like to look at end-tidal more often. In the less severe, very well-compensated patients, we like to look at the end-tidal. But in most of them, we look at both. And there is almost a linear relationship there. So higher VE/VCO2 is worse, and lower end-tidal is worse. What about tracking with exercise? We're looking here at a patient that was placed on a prostanoid, 32-year-old woman. She had idiopathic PAH. And pre-prostanoid, you can see I tried to match the x-axis and stretch the figure on the right so that the x-axis would match exactly. But you can see here that she had a peak VO2 around 0.9 and that the peak VO2 went up to 1.4 after the treatment with the prostanoid after several months. So she had not only a clinically relevant and bedside improvement, and historically, based on functional class, she had some improvement, but she also had an improvement in VO2. Now, more importantly, that fingerprint, if you will, of pulmonary vascular limit to exercise, here was a VE/VCO2 that started off high at around 50. It failed to decrease during exercise, so you see 6 and 9 minutes, it's not going anywhere. And that nadir, or that anaerobic threshold value, is around 42, 44. So here it is after the prostanoid, and it starts off lower, and it drops down very nicely into that range that's actually less than 34. So not saying that we cured her, she's far from it, but she had a dramatic increase there, and based on that fingerprint, you could tell that it wasn't just because she was training, it wasn't because she learned how to do the bike better, it was actually because she became more efficient at delivering blood to the lungs, and the VE/VCO2 ratio dropped. So what about the screening tool? What about unmasking for pulmonary hypertension? The CPET can differentiate various etiologies of exercise limitations. So if you're trying to take a patient, let's say, who has exercise intolerance, you might be able to figure things out by stressing the system. And in terms of the pattern of exercise gas exchange, this is a paper that came from our center also, where we looked at patients who had COPD, heart failure, PAH, and normal. And the reason for this is because those patients with heart failure on the left side and COPD also have exercise intolerance, and they also have abnormalities in gas exchange. But you see here This is mixed expired CO2 relative to end-tidal CO2. That ratio is really low in the COPD patients. It's high in the heart failure patients, but it's even higher, even worse in the PAH patients. But more importantly, look at the pattern here of the patients who have the various diseases. So the open figures are the resting figures, and the triangle there are the normal, the star are the COPD, the square are the LV failure, and the circles are the PAH patients. So if you go from the open at rest in the normal patient, maybe here I'll use the pointer for all you that are here, you go from normal and your end-tidal CO2, instead of dropping, actually goes up, and you have this pattern over here at the anaerobic threshold and at peak. And then when you look at the squares, the LV failure patients, they do the similar pattern, but they start off at a lower end-tidal CO2. And look at the PAH patients here. They're extremely different. In fact, they don't even go in this direction. The end-tidal drops down because of that ventilatory inefficiency, and they're going the wrong way. So if you learn to recognize these patterns, however you want to plot them, you can see that the pattern of gas exchange can be used very nicely to determine what the nature of the impairment in blood flow, if you will, is limiting that patient from doing exercise. So it's extremely important, I think, in the scleroderma population. As Dr. Hyland said this morning, the scleroderma population behaves a little bit differently, and they can have many other reasons to have exercise limitation. In fact, they're often limited by musculoskeletal abnormalities, and they can have some left-sided heart disease. So more generic measures that we use now for looking at impairment, like just peak VO2 alone, and in fact 6-minute walk, may not be so reliable as to help us out in terms of severity of the pulmonary hypertension, let alone diagnosis of what the pulmonary hypertension is. This is the money of what you get out in output when you do a cardiopulmonary exercise test in Dr. Wassman's lab, and hopefully worldwide he's sort of trained the rest of the world in how to do this. It's called a 9-panel plot. And I'll just focus on panel number 6 here, which is the VEV-CO2 over time. And you see that same thing. I'm just reiterating the concept that you see the high VEV-CO2 at rest, and then it fails to drop during exercise. It stays well above 34, and this is an abnormality that can easily be detected. Here is VO2. VO2, of course, there's oxygen at rest when we have to deliver blood to our tissues. We have a resting oxygen consumption, and that's used for the Fick equation when you're measuring cardiac output. And then with unloaded cycling, you can see that there is an increase. And then here's the wattage, and as the wattage kind of goes up here, so does a little bit the exercise related VO2, but it's blunted. It doesn't go up nearly as sharp. It doesn't go up to a peak. The predicted is way up here. This patient is pretty significantly impaired, and if you were to just look at that alone, you would say, all right, there's impairment, but I don't know why. If you were to couple that to this fingerprint here, then you will understand that the patient has a pulmonary vascular limit to exercise and be able to proceed further there. So in screening asymptomatic CTD patients, we are in the middle of a process trying to look at patients who have a high risk of developing pulmonary vascular disease over time. If we wanted to screen for idiopathic PH, it's 1 in a million per year. It'd be pretty impossible. If I put all of you through cardiopulmonary gas exchange for the next 100 years, it's unlikely we'd get any one of you, if you're all normal to start, to develop pulmonary vascular disease. So we want to get a target population that we think has a higher risk of developing pulmonary vascular disease so that we can at least plot the natural history and see what they were like before they developed overt pulmonary hypertension. So in this case, I'm showing you 3 different versions of a gas exchange measurements, the normal patient and the reduced peak VO2 patient and another reduced peak VO2 patient. So you see here normal, they go up to their predicted. The rate of rise is parallel to the wattage increase, and so the slope is normal. And here the rate of rise is not parallel, it's blunted, and the peak is reduced, and the same thing here. Now, how do you differentiate between the two? Well, this particular one, you see the VEV-CO2 is high, and this particular patient, even though VO2 is really reduced and the patient is symptomatic, the VEV-CO2 is normal. So we would conclude that this is PAH and this is not PAH. And so without putting all of our eggs in one basket, we of course would do the other tests. We always do the echo and the right heart cath, et cetera. But it is very useful to have this going in when you're trying to differentiate what the problem is, especially if there are multifactorial causes, as again Dr. Hyland pointed out, particularly prevalent in the scleroderma patient population. So what about doing this in combination with exercise? The problems with exercise hemodynamics is that there's poor definition of an abnormal response to exercise. So we used to use a PA pressure mean of 30 in the guidelines or in the proceedings from the world meetings. And we used to say that 25 isn't good enough, you need to really exceed 30. And then if it's 35 or 40 or whatever, then you can say, all right, well, this is a pulmonary hypertension patient that we unmasked who has maybe normal pressure at rest, but because they go beyond 30 with exercise, they have pulmonary vascular disease. Well, it's just not true. And what happened was at the Nice meeting, it was Horst Olszewski from Gießen in Austria. From Graz in Austria, where he did a literature review and he just looked at what people were reporting for peak pressures during exercise. And he found a lot of normals that were high. I don't know if this is rumor or it really was true, but the rumor has it that Lance Armstrong, when he was doing his training, had PA pressures in the 80s. And this guy clearly did not have pulmonary vascular disease, right? His pressure was in the 80s because his flow was torrential. The pulmonary vascular resistance, if you had measured it, would be low. And we'll get to that in a second. The other problem is, so here's what we were talking about. The hemodynamic definition here, exercise was removed from the definition in the 2008 meeting. So there's a heterogeneity in protocols and measurements. So how much do you exercise somebody? If the pressure is proportional, if the pressure increases proportional to the effort during exercise, you suddenly have effort dependence on a test that you can't really standardize. And so that's a problem. And then measuring, how do you measure it? There's chest wall movements that increase interthoracic pressure. Well, here's how they do it at Harvard. There are more people in the room than you would really be comfortable with in our lab because we don't have enough space. So you see the patient has the PA catheter, you see the patient has the nose clip in place, they also have a radial art line, and you see all the machinery going around here. And if you actually count out the number of individuals that are in this room dealing with this one setup, it's 7. So it's not something that you can just sort of set up and you can do 10 of these in a day as the patient comes in and you're a machine. It takes a lot of doing. Kind of like setting up 3 conferences around the world with audio-visual. And counter that with what we do, which is just 2 of us, really. And in fact, you don't really even need a physician. I like to stipulate that a physician is always present when we're exercising a PH patient for obvious reasons. But other than that, you don't need the technical aspects of the physician around. So here's a plot of mean PA pressure and cardiac output. And it turns out, this is from 113 non-invasive and 24 invasive measurements, that the dynamic PVR, the change in PVR, describes the functional state of the pulmonary circulation rather than just what's the PVR at rest or what's the PVR after one point of exercise. So you look at this point where we're going to define 3 millimeters per liter of minute increase corresponds to maximal resistance of 3 Wood units in total pulmonary resistance during exercise. And that point is 30 divided by 10. So for every increase in 1 liter, you should see a maximum of 3 millimeters of mercury rise. And in fact, that's the upper limits there. The slope should not increase more than 3. And I drew in on this. This is actually 3 and 3 and 3. So this was sort of drawn in as a physiologic range. And this is the actual slope that if you were to measure those patients in predefined normal patients, this is where you would get. So they actually have even less than 3, especially as you get upwards of higher cardiac outputs. And this is, again, why you typically see PVR actually drops a little bit during exercise. It doesn't rise. PA pressure can rise in both instances, in disease and in normal. But exercise is normally associated with a decrease in PVR overall. So here is a publication from the Harvard group that came out in 2013. And as you see, there's 4 different groups. There are the normals here and the scleroderma with no pH here. And they're both to the right of that slope line of 3. And then you have the scleroderma patients with pH. And then you have the idiopathic pH patients who typically hemodynamically are worse. But both groups are to the left of this line, and they have an abnormal PVR response. So again, it's pattern, it's change over time that we're looking for. There's that slope. So what about screening in the populations for unexplained dyspnea, for relatives of heritable PAH patients? So that's the other potential population that you think are going in their lifetime to develop PH if you already know they have a gene. There's some ethical issues with patients not wanting to know if they even have it. So I don't know if you can capture a proper denominator. Question HIV, because the prevalence is certainly much higher than 1 in a million, but in some HIV clinics, it's actually much lower than 1 in 200. And the CTD patients we talked about. So the hypothesis is that exercise-induced PAH in these cases is a mild yet symptomatic phase of the disease. Here is what the Harvard group published when they came up with their CPET as a way to screen. They found out that it wasn't the perfect screen, that VCO2 on its own wasn't that great. They looked at the log of the mean pressure divided by the log of the VO2, and they found out that the patients who had PAH, at least half of them, had this plateau pattern. So it wasn't uniformly everybody had it, but a large number. And the 14 of the 15, almost all of them who were normal in these patients where they had a takeoff. So let's see, did I say that right? Yeah, so these were the patients with exercise PAH, and these are the normal patients. So again, you're looking at patterns, and something that might help you at least determine that there's sort of an intrinsic response abnormality in the pulmonary vasculature of patients who are predisposed to developing PAH. But over time, those patients may not develop PAH. And I left the slide out here, but let me just say that there was one study where they did, I think they looked at something like 32 patients who had resting pressures that were normal, and with exercise, they had a certain percent, maybe half of them, that had exercise-induced mean pressure greater than 30. So at the time, they were still using that definition. And of those patients over time, some of them continued to have resting echo pressure or resting cath pressures that were normal and that went up over 30 with exercise. Some of them actually stopped being abnormal, and they were normal at rest and during exercise, or at least less than 30. And one of those 30-some patients actually developed resting pulmonary hypertension. So from the standpoint of screening, it was a plus in that they picked out that one, but from the standpoint of likelihood, even in all those patients, if they had a PA pressure that was high, most of them didn't develop anything. And so using this as a way to sort of pre-treat or treat them to see if you can prevent, you'd have to be using a lot of medications in a lot of patients before you prevent one using that kind of diagnostic criteria. So just to conclude, the measurement of the gas exchange, especially the pattern of gas exchange during exercise, provides important insight into the mechanisms of exercise limitation. Exercise, we think, can unmask underlying pulmonary vascular disorders when CPET is used. And invasive CPET seems to add the utility in unexplained dyspnea in characterizing the pulmonary vascular response and possibly screening for pulmonary vascular disease in a more meaningful way that says not only we have gas exchange abnormalities, but in fact we have the physiologic hemodynamic response that's abnormal, and look out, it might get worse. Thank you.
Good afternoon. Thank you, Neil, for the kind introduction. So I'm the last talk of the afternoon. Hopefully I can walk you through this topic of advanced interrogation of the pulmonary vascular tree. I'm going to show you some basics, but then we're going to get to more newer approaches. This is part of the European guidelines, and as you can see, in the right lower corner of the screen, after you screen the patient for the signs and symptoms of PH, you do an echocardiogram, you rule out left heart diseases, lung diseases, you do a VQ scan, and the patient goes to a PH center. Then it's when the patient gets a right heart catheterization that will confirm the diagnosis of, in this case, pulmonary arterial hypertension. These are the definitions. Dr. Hyland already talked about them, so I'm not going to go into it, but the right heart catheterization will help you differentiate. First, make a diagnosis of PH, and then differentiate precapillary from postcapillary pulmonary hypertension. In addition, the right heart catheterization will also give you some values that will help you classify patients in a low risk, intermediate risk, or high risk category based on the 1 year mortality less than 5, 5 to 10, and more than 10. And the hemodynamic determinations that the guidelines consider are the green zone, the yellow zone, and the red zone, depending on the risk you have. You certainly don't want to be here with a right atrial pressure more than 14 millimeters of mercury, a low cardiac index less than 2, and a low SVO2. Just to continue with the guidelines, they talk about when do you follow patients with a right heart catheterization. The suggestion in general is to do it in cases of clinical worsening and 3 to 6 months after changes in therapy. There are some centers that will do right heart catheterizations every 6 to 12 months. This is article that shows the great variability in order right heart catheterizations in the U.S. And as you can see, some centers will do it every 3 months after initiation of therapy. Some centers will do it every year. Some centers, 60% of the centers will do it after adding or changing therapy, and 47% of the centers will do it if patients worsening. So there's no clear answer when to repeat the right heart catheterization. For certainly, you need to do it for diagnosis, but as a follow-up, there's no clear cut answer. For the evaluation of patients that are going to have right heart catheterization, there are a lot of things that are very important. You want to check the coagulation profile. Nowadays, we are leaning towards doing right heart catheterization even when patients are on Coumadin if the INR is between 2 and 3. If the patient had prior difficulties with vascular access, you want to know, oh yeah, they tried several times on the right side, they couldn't access, so obviously you want to move to another area. If the patient is allergic to medications, particularly lidocaine, or contrast dye if you're using it. If the patient has congenital heart disease, because you may want to change a little bit your approach. If the patient has left bundle branch block, you also want to be aware, because as the catheter goes in, you can touch the AV node, and you can have a complete block, so you need to have some availability of a pacemaker just in case, in that particular case. The patient needs to be able to be flat. Some patients cannot be flat. I need to be sitting. I mean, at 45 degrees, I have done it sitting, and never. I don't think that's possible. In medical hardware, you want to be sure that the patient has an IVC filter, because that complicates the access from the leg. And if you have a medical tricuspid valve, also there's a contraindication to do the catheterization. You can do it with biological valves, but not with mechanical ones. Risk of pregnancy, so you need to cover all that area. You need to be talk with the patient, risks and benefits of doing right catheterization in the event that they may be considered to be, there is a possibility of being pregnant. And then if you have right heart masses, this is another thing that at least scares me when you see thrombus in the right atrium, or the masses in the right atrium that could be cancer, or if you have right side endocarditis, you don't want to dislodge any of that. So I would avoid doing a catheterization in that case. And then if you have a history of angina, of congestive heart failure, or severe aortic or mitral valve disease, moderate to severe, and you may need a left right catheterization to measure an LVEDP, then you need to plan for that and send the patient to the appropriate operator that will be able to obtain that number for you. During right heart catheterization, you measure the pressures, you calculate the PVR, in the appropriate case, you rule out left to right shunts, but you do a shunt run, and you do pulmonary vascular reactivity, and then you do some other testing that we'll be talking here in a minute. The 5th World Symposium, 2013 publication, mentions, as well as the European Respiratory Society and European Heart Society guidelines, that the right heart catheterization ideally should be performed in expert centers, so centers with experience doing this, because of all the complexities that I'm going to show you in a minute. You need to be sure that you have the appropriate zero level, because if you're not, then the numbers are going to be up by a certain percentage or lower by a certain percentage, and it will be very hard to know that if the cath was done well or not, because there's no clue when you read the report whether that level was appropriately zeroed. I'll show you a picture. The wedge should be measured as a mean of 3 determinations at the end of expiration. And cardiac output, ideally you want to do FIG method that we do in a good number of patients, but as is cumbersome, thermal elution is the next best alternative. And then you do obviously shunt run, particularly when patients have a high oxygenation in the pulmonary artery that suggests a left or right shunt. This is how you zero the catheter. You want this. You have these 3 planes: the frontal, the transverse, and mid-sagittal plane, and this will correspond to the mid-axillary line between the base of the xiphoid process and the bed of where the patient is lying. So half of that, and then the 4th intercostal space will be the other plane, and there's where you want to put your transducer. This is what is the cartoon that we have for the nurses, where we show exactly how things are connected. Just a reminder that the Swan have several ports, but the number 4 there is the distal port. Then you see here in the right atrium number 1, the proximal port, or the right atrial pressure measurement. And then you have these 3, which would be the line for inflating the lumen for inflating the balloon. And number 2 is where the temperature is measured for cardiac output determination with thermal elution. So the risk of right heart catheterization are 1.1%. There was a study that was able to obtain information, most of it retrospective, maybe a third prospective, and they found that 1.1% of complications is what usually occurs during right heart catheterization. Mostly of those complications were minor, hematoma, arrhythmias that were reversible. The mortality is approximately 1 in 2,000. And as you see here, this is the table that the article provides, with 4 fatalities out of these 7,000 patients, 1 disability, and a few hospitalizations. Overall, a pretty safe procedure. All these were done in referral centers. Wedge, I'm going to be talking about these measurements because it's just so important, as a lot of errors occur when this is not appropriately measured, as you can misclassify patients from precapillary to postcapillary pulmonary hypertension, or pulmonary arterial to pulmonary venous. There are 5 criteria, and these criteria are essential, and every time I do a cath, I'm sure that all these criteria are met. The wedge should be less than the diastolic pressure because you need to have a gradient. The tracing should reflect the A and the V wave. You need to see the catheter. You will see images in a minute. The catheter is stuck there. It doesn't move because it's just wedged. And then you have free flow on the catheter. You can do a flash test. You just flash the catheter and you see a square sign. Rapidly the waveform returns. I mean, there is patency distal to the tip of the catheter. And then you suction blood out of the catheter, and you get arterial blood because the blood, after you remove 5-10 cc's, you get blood coming from the left atrium, which is arterial. So you want the oxygenation certainly be above 90% in that blood. There is this article that I have to mention from Halpern, who showed discrepancies in the measurement of wedge when compared to the gold standard left ventricular diastolic pressure, which is done by poking the femoral artery and going up to the LV. And he found that half of the patients presumed to have pulmonary arterial hypertension based on the wedge, may end up having pulmonary venous hypertension. The discrimination of the wedge between patients with high and low LVDP was okay, but nothing exceptional, and you can see the limit of agreement here between the 2 techniques is high. But this was a retrospective study. The quality of the wedge was really not assessed. There were a lot of patients. One of the potential issues is that the way we measure the wedge, we tend to measure it here in the mean of the A wave, but as you can see in this graph, probably better to measure it at the tip of the A wave because it closely resembles the left ventricular and diastolic pressure. One of the things that the article is saying, the prior one I showed you, is that the LVDP tend to be higher than the wedge, but maybe it's where you measure it. Then the other thing is that you want to be sure that the catheter is well placed. And I previously did a study showing that you get the best accuracy in measuring the wedge when you inflate the balloon and half of the volume, because that allows you to go a little deeper on the vessel and get a better seal. Same with the left. Sometimes you do in the right side the wedge, it doesn't work. You have to move to the left side. As you can see, the left side is better because it's just a straight shot down, and a catheter fits perfectly well on the right side, as you see here. The catheter can be just touching the wall, and the balloon is inflated. You're injecting contrast. You see, this is not an appropriate wedge. Could be damp there. You're not facing the lumen. The catheter is certainly not an appropriate position to get a good determination. In the next, in this other one, you're inflating the balloon here. It's on the left side, you're injecting dye, and as you see, you're injecting dye. There's also non-contrasted blood coming into the vessel. So you have an incomplete wedge there. So you see probably again, as you see the dye goes in, but also this non-contrasted blood coming in there, incomplete wedge. That's not an adequate measurement. This one, half balloon inflation, left side, the vessel fills completely. If you don't do anything, that contrast will stay there for hours. Obviously, you don't want that, but I'm just telling you there is no movement of blood. And this is reflected on the waveforms you get. The one I show you from the left, and also the distal right, you see the A and the V waves and an appropriate determination. This is here an incomplete wedge. As you see a mixture of the waveform from the pulmonary artery and the wedge position. Another case where you see a good measurement here with half balloon inflation, and you see just a poor filling of the vessel because of these incomplete wedge on more proximal branches of the pulmonary tree. So why don't we do LVEDP on everyone? What will be the issue in doing that? Well, it increases the risk. You need to do an arterial puncture. You need to use the leg. The neck is easier for right catheterization. And as you go with the catheter, you can dislodge some plaques of atheroma and cause TIAs or worse. So yeah, you do need to consider when to do the LVDP, and in general, the consensus is that not do it unless you're suspecting left heart dysfunction. If you think the patient has heart failure with preserved ejection fraction, you have signs, a large left atrium, grade 2, 3 diastolic dysfunction, the phenotype fits, then I think it's appropriate to do the left heart catheterization and the LVDP measurement. We just came with this article. We contributed with this subgroup of patients for validation of the results. And Wasim Fares was able to show that this ratio of the right pulmonary artery, right atrial pressure over wedge ratio, right atrial pressure over wedge, may be a good index to predict survival, as you see here in the two graphs below. As the right ventricle starts failing, the right atrial pressure will increase and it will be higher compared to the wedge, will be a reflection of the left atrium. So that ratio would be a predictor of poor RV function and survival. And as you see, the patients with a ratio less than 1 are in blue, doing better, and the ones in red had a ratio of 1 or above, doing worse, with a 4% increase in mortality in a year per 0.1 increase in the ratio. Then you have the cardiac output, and the guidelines will say, hey, ideally you want to do direct FIC. This is not done in majority of institutions because it requires special setup. I'll show you in a minute. So thermal elution is the next best alternative. You don't want to do that if you are suspecting intracardiac shunt, as the number may be inappropriate. There's this thing called indirect FIC, where there are at least 3 different formulas to estimate oxygen consumption, and then you divide that by the difference in arteriovenous content, and you get the what called indirect FIC cardiac output. There's a lot of discrepancies when compared to other terminations, like in this case, thermal elution. You may see an error of 3 liters and 2.6 liters above and below for a limit of agreement. And then you have the thermal elution. This is the study we sent to ATS, so I'm just going to show you this little graph. In 57 patients, we measure cardiac index by thermal elution, and we measure cardiac index by direct FIC, and we see that the bias is 0.2, so in general, a thermal elution may be tiny bit above the cardiac index measured by FIC, but there is a limit of agreement of error from 1.8 to minus 1.4 liters per minute per meter square. This is particularly predominant as you have higher cardiac indices, and it does not relate to the type of pulmonary arterial hypertension. The severity of the TR also not relates. It mainly relates to how high is the cardiac output and how high is the TAPSI, meaning also a parameter that goes along with the higher cardiac output. This is how we measure it in our lab. After the right catheterization, we sit up the patient. This is a fellow that worked with us. Allow me to use the picture. We connect the mask. This is a very soft, we call it pilot mask. And this goes to this metabolic card, and that will measure oxygen consumption. So we do not calculate it by a formula. We measure it directly. It takes 15 minutes. The machine warms up in 20, 25 minutes. So you start adding times, and it's cumbersome, and I'm sure not really available in a majority of places giving all these setup that you need to have. Another source of error that I've noticed, and I think it's pretty interesting, is that the pulse ox, lots of centers, in fact, where I worked before, we didn't do arterial puncture, so we just use the pulse ox. Pulse ox have a good number of errors when compared to the arterial oxygenation. And as you see here, the pulse ox may be 3.2 millimeters or 3.2 percentages higher than the oxygen saturation that you measure in the arterial blood. And that may affect your calculation of cardiac output. And this is in part because of the carboxyhemoglobin that the pulse ox may not be able to differentiate from the oxyhemoglobin. So it's something to take into account that if you really want to get this number right, you need to do arterial puncture, so we do that. And then other ways of assessing the circulation are, for example, one of them is the vasodilator testing. And you want to give to the patient ideally nitric oxide, because if you only give it 5 minutes, there's practically no side effects of it. And then you see if the pressure decreases at least 10 millimeters of mercury or more to a value less than 40. And with that, you can say, well, in the appropriate setting, the patient may be a candidate to try calcium channel blockers, particularly if they have idiopathic, heritable, or an oxygen-induced pulmonary arterial hypertension. In other patients responsive to vasodilator testing with nitric oxide may suggest that the circulation may be more reactive, maybe healthier circulation, lower age. Some patients do better when they have a positive vasodilator testing. This is what the guidelines recommend. In general, they prefer nitric oxide. As you see here, the time also is just, you give it a one time, 5 minutes, boom, 20 parts per million, for example, and you're done. For ibuprofen, you just have to keep on increasing the dose, and each increase has its time. So you see here, you can add up to 20 minutes, 30 minutes. The same with adenosine, you also need time for each increment that you do. This is just to remind you that the vasoreactivity per guidelines is only recommended in idiopathic heritable and pulmonary hypertension associated with anorexogens. When you have that population, for example, idiopathic patients, you do this test, 10, 15% will have a positive test. However, half of them will respond to long-term calcium channel blockers. So you want to follow these patients with another catheterization, be sure that they're responding, follow them clinically, and confirm that the treatment is effective. This is just to show you in a table that the anorexogen-induced, the idiopathic, are the two main groups in whom long-term calcium channel blockers worked. In other patients, even when they have, for example, a positive test in 8% here, the none respond to long-term calcium channel blocker. That's why the guidelines do not recommend doing the vasodilator test in that population. This is a positive test. You see large waveforms there going up to 90 here with a mean of 50. Nitric oxide, boom, the mean pressure decreased to 30, so you have more than 10% decrease, and certainly it was lower than 40, so it's a positive test. In the appropriate setting, you can try calcium channel blockers, which should be giving a high doses. Other things you can do are fluid challenges. You can measure hepatic wedge, do some other maneuvers that if I have time, I'll talk to you about. And I don't do this, but in the appropriate setting, you can also potentially do a pulmonary angiography if they're suspecting chronic thrombotic pulmonary hypertension. Some patients with group 2 PH, the radiocatheterization is enough, it's not enough to rule in or rule out this condition because the wedge may be normal. So in these patients with group 2, the way you diagnose them is when they have high wedge. But the wedge may be normal if they didn't eat with salt in the last few days, you put them NPO for the radiocatheterization, they have an early stage, they are taking diuretics and now they're very compliant, or they have an early stage of heart failure with preserved ejection fraction. Those patients, you can do a fluid challenge. We do 500 milliliters in 5 minutes. And then you see how the wedge increases, and an increase above 15 to 20. Some guidelines says 20, anything more than 15. And if you want to really be super obsessive, maybe 20 or above will qualify you as having heart failure with preserved ejection fraction. And if in these patients you give nitric oxide, or any patient you give nitric oxide, and you start noticing that the wedge goes up, that might be that you are dilating pulmonary circulation, more flow is going to the left ventricle, and now the wedge will increase as you are uncovering an occult heart failure with preserved ejection fraction. This is also recommended in the guidelines of the Fifth World Symposium. They describe a value of about 15 with the amount of fluid that I previously mentioned as a positive test. And they even say that it's safe and it's able to discriminate patients with pulmonary hypertension from those with left ventricular diastolic dysfunction. This is a study of patients undergoing radiocatheterization. And they noted that 22% of the patients that initially were thought to have pulmonary hypertension, when they gave the fluid challenge, the wedge increased 15 or above, and they found that those 22% of patients had the phenotype than patients with pulmonary venous hypertension. As I go here, the ones that were diagnosed with pulmonary venous hypertension after the fluid challenge tend to be older with hypertension, diabetes, obstructive sleep apnea, left atrial enlargement, LVH. So this may help differentiate those patients that look like pulmonary hypertension by numbers, but they have a phenotype that mostly resembles a pulmonary venous hypertension. You can give fluid challenge and make that differentiation. Fluid challenge has some advantages. It has less impact on blood pressure and heart rate than exercise. It's widely available. You don't need the bicycle and the expertise to do the exercise. And older women have a steeper increase in the wedge when giving this fluid challenge, suggesting reduced reserve flow in these patients, and one of the explanations why women may be more predisposed to heart failure with preserved ejection fraction. As you see here in the slope, the one here, women of older age will have a steeper slope when given saline, and the same here, the slope is steeper in women than in men when given saline. So the wedge goes up faster. This is just similar. As you see here, as the cardiac index goes up on these patients as you're given the fluid challenge, the mean pressure increases faster in women, particularly older women. In patients with scleroderma, it's also important. If you give the fluid challenge, you may help distinguish these patients, particularly this occult pulmonary venous hypertension, which is important because this is one of the, at least the authors mentioned in this article, that one of the explanations for what patients with scleroderma may not respond to pulmonary arterial hypertension therapies is that they may have this occult pulmonary venous hypertension that you only pick up when you do the fluid challenge. Yeah, not a lot of patients, but 11 out of 53, and those patients will be qualified as pulmonary arterial hypertension if you haven't done the fluid challenge. Then what we do also during the right catheterization, if the patient has cirrhosis, in the same procedure you can also measure the portal pressure. And if the portal pressure is above the portal gradient, which is defined as you see here, the wedge hepatic minus the free hepatic venous pressure, if that's above 5, then you do have portal hypertension, and that may be one of the explanations why you're having pulmonary arterial hypertension, so portal pulmonary hypertension. The way you do that is with the same catheterization and a wire. You somehow go into the suprahepatic vein, inflate the balloon, then you want to be sure by injecting contrast that you're well sealed, like in that picture. And then as you inflate the balloon, boom, the pressure goes up. If you have portal hypertension, the pressure will remain about the same if you don't have that, but you certainly see the jump. Like in this case, the transvenous gradient was 22 instead of 5 or below, which would be normal. We're now doing something more for research, although we have had a few patients that had dizziness when moving their bowels or when doing a Valsalva maneuver. So we do a Valsalva maneuver during the catheterization. There is some data of doing Valsalva maneuvers, particularly measuring blood pressure in patients with PH. And as you see here, patients with PH will have higher, more pronounced dip of the blood pressure as soon as they release the Valsalva maneuver. And the recovery time is also prolonged, and the heart rate doesn't go up as much, meaning that they may have some sympathetic dysfunction, that the sympathetic system is not able to catch up with this rapid sudden hemodynamic change, because when you do Valsalva maneuver, take a deep breath and push, the venous return will decrease, and the blood pressure will go down, but then as soon as you release it, they have this dip here and they cannot compensate and they could pass out. So the authors, in fact, mentioned that this may be one of the reasons why the patient have syncope, particularly when you cannot explain that by arrhythmias. Let me just show you one thing. We're also putting a balloon in the esophagus to measure the pleural pressure, because we have noticed that particularly in patients with obesity or COPD, the pleural pressure increases, and that may falsely increase your wedge and your pulmonary pressure. In that case, we measure the pleural pressure and we adjusted the mean pressure of the wedge by subtracting the pleural pressure from its number. So in conclusion, the right catheterization remains a necessary intervention for diagnosis and follow-up of patients, as well as prognostication. Errors in the measure of wedge are common, and I show you some few examples. Exercise and fluid challenge are adequate methodologies to stress the circulation, and other methodologies like the Valsalva, the pleural pressure measurement, the vitamin challenge, I didn't show it to you, are currently being tested and probably will become available in the future. Thank you.